So Harry Quilter-Pinner has very kindly agreed to lead the seminar today and is going to give us a presentation on his topic, Who Cares? Financialisation in Social Care. And he's going to talk about some research which he's recently published as well with the IPPR. Harry is a Senior Research Fellow in the Work and Welfare State team at the Institute for Public Policy Research, and he heads the Better Health and Care programme there. So could hardly find anyone better suited to talk to this particular group and to those who join us for our online seminars. We started an online seminar series in March for obvious reasons, and Kelly and I have just been talking this morning about our plans to continue that right through the autumn into Christmas. So we'll soon be announcing new plans for the series that we hope to continue. We've had some excellent speakers, and I'm sure Harry will be one that we'll be very pleased that we had invited. We'd actually invited Harry to Sheffield before the lockdown, and so we've rearranged this date, and it's very good to see that we've got a good audience attending from quite a wide geographical spread, some of whom doubtless would not have been able to hear you, Harry, if we had actually been in Sheffield. So welcome to the Sustainable Care Seminar Series.
Thank you very much. It's great to be here. In the invite that I got to come up before COVID, there was a meal promised, and now we've got Zoom and there's no meal, but we'll have to make do with an intellectual feast instead. So thank you very much. I'm going to share my slides, and I'm hoping that this will work, but someone shout at me if it doesn't. Yeah, let's share this. Can people see that?
Yeah, it's working fine, I think. Yeah, I can see it, Harry. Great.
I can no longer, because I'm sharing, I can no longer see you, so shout at me if I'm missing anything or if people want to interject. So I've actually taken the liberty of slightly broadening the scope of what I'm going to talk about to incorporate a number of pieces of research that we've put out in the last year. And I've partly done that because which will incorporate the issue of financialisation, but go a bit broader, because I think the moment that we find ourselves in on social care is so fascinating and so important. So I will briefly introduce the work that we've been doing and the kind of the exam questions that we've set as an institute on social care. I then will talk through the research, and then I will also, because our main thing, obviously, at IPPR is policy, I'll also talk through what we've been recommending and some thoughts about the reform agenda from now on. And then it would be great to get kind of everyone's take, ideas, questions, etc. So, you know, most conversations about social care, as everyone on this call will know, start with the question of funding, because there hasn't been a long-term funding settlement for social care. And I'm talking here about adult social care primarily, although it probably is as true for children's social care and younger people as well. And pre-COVID, there appeared to be a moment where there was a kind of big discussion about funding, and I'm obviously a skeptic because we've heard this so many times before. I mean, let's see Richard on the line, who will have gone through many iterations, as I'm sure others on the call will have done as well, of various governments saying they're going to put funding into the system, but without it happening. So I am a skeptic, but having said that, there did seem to be some intent in government prior to COVID to deal with the funding question. And there was an active conversation going on behind closed doors about what the options were and what the solutions were. And IPPR for quite a while had been advocating for the introduction of free personal care in addition to funding to return access levels to previous levels, 2015 or earlier, ideally. And that was definitely on the table. We were in conversations with government. Free personal care was one of the options on the table, which we were obviously quite surprised about. It's quite a bold move, but and so we started a conversation. One of the bits of feedback we got back from government and from other stakeholders was the concern around, if you're going to put funding, significant additional funding into the social care system, into the care system, what do you have to do to make sure that money is well spent? And there's a growing question about, that the problems that face the system would not be solved by funding alone. So what you do alongside that funding becomes even more important. And we kind of conceptualized the issues facing the sector, which is a bit of a simplification, in these three that are on the screen now. So access, huge levels of unmet need, and people who need formal care not being able to access it, either because they can't pay for it or because the state's thresholds for accessing state-funded care were such that they weren't entitled. The quality of that care, and I'm thinking here very holistically about quality. So obviously there's kind of, and I'll talk a bit about this in a minute, kind of what CQC would deem kind of safe, high quality care. But there's obviously a broader definition of quality to include kind of relational care, preventative care, care that enables people to live longer in the community, happy, healthy lives, a much kind of broader conception of quality, as well as a narrower one of like what is good quality residential care or domiciliary care. And then there's the problem of financial stability in the sector, and are the providers that are providing care, are they spending that money effectively? Are they financially viable? How do we ensure that there aren't big failures like some of the ones we've seen in recent years? And we set out to do a program of work that tried to set out what you need to do in addition to putting money into the system to address those three big concerns. And in particular, we kind of started off with the hypothesis and the argument that additional funding would increase access. So on the first box, definitely funding is key, but that you'd have to do quite a lot more in addition to drive up quality and stability. But what are those things? So we set out and we formed a partnership with, it's actually three other organisations. I should have added a fourth, but Independent Age supported our work, and we worked with them very closely. And we partnered with Future Care Capital. So for those of you who don't know, Future Care Capital are a charity, and they have a trust, and they do research into particularly kind of the use of data and technology in terms of driving better care. And we also, Future Care Capital, to do their bit of this work, which I'll talk through in a minute, they partnered with Cambridge Economics as well. And we published between us these three outputs. So Who Cares? The Financialisation of Adult Social Care was the piece that we were focusing on when we first envisaged this talk. But following on from that, we published Ethical Care, which focused partly on the issue of financialisation, but also the issue of quality and how you drive up quality. And then Future Care Capital published a report called Data That Cares, which was really all the, quite a lot of the more complex quantitative analysis that sits behind the two policy papers that we published. And in an ideal world, I would have Anne-Marie Naylor from Future Care Capital here, because I'm going to try and summarise some of their more complex work on particularly kind of financial stability in the sector, and she would do a much better job of explaining it than I will. And if you ask any difficult questions, I'm going to have to pass you on to her, I'm afraid. So I will briefly talk through the analysis that we did, what we found, and then the policy recommendations, focusing in particular on the questions of quality and stability, as I set out at the start. So we basically undertook several kind of types of research. We did a lot of data analysis, and in particular, we linked, or we pulled together the data from CQC and NHS Digital, local government, and from companies' house data, so data that's out in the public realm, but not necessarily usually kind of brought into the social care conversation. And we created a big database that joined all of those data sets up. We did lots of analysis on that, which I'll talk through. We also did lots and lots of interviews with commissioners, providers, policymakers, and we did several kind of policy workshops to develop the policy response. So that's essentially what I'm drawing on in kind of summarising the findings here. So this is not going to be a shocking finding. It's basically CQC data, but what we found is actually, according to CQC, and that is probably the best metric we have for quality in social care, things have been getting a lot better over time, but we've still got, you know, roughly a fifth of providers that are not meeting the standards that we would want. And as we all know, that there's huge variation across the country, and in particular, you know, there are cold spots, areas where there is just kind of essentially care deserts, which is both about a lack of provision, but also a lack of quality provision. And also in our kind of assessment of quality, one of the things that was interesting is if you look at the social care outcomes data, which is usually survey data, actually, again, quality is improving across most metrics, the exception being social interaction, where the data is really clear that the recipients of formal care feel that their level of social connection has deteriorated, which is unsurprising given what we know about the cuts that local government have made, both to the kind of non-statutory elements of social care provision, but also to their wider array of services that might have provided more of that social connection. And there's a kind of consensus in the interviews and in the literature that, you know, social care has done quite well at maintaining quality over these past few years, since 2010, in the face of austerity, largely by restricting access, so maintaining the quality for those who receive it, but restricting access to a smaller number of people. But that the kind of pressures are getting to a kind of tipping point beyond which it will be very hard to sustain quality if there is no more, if the funding settlement is not put in place. And we then kind of looked to set up what are the drivers of quality. So in addition to putting more funding in, you know, what will we have to do with that funding, and in addition to that funding, to ensure that it improved quality. So this first slide, you know, looks at, you know, one of the big drivers being the funding cuts, as you know, impacted on quality, and in particular through the literature review and through conversations with people on the front line, there was a few channels through which people felt that funding in particular had damaged quality, and which we'd want to focus on if we were going to put together a funding deal, in addition to just improving access. So one was funding of non-statutory services, so those services that would provide connection to work or meaningful activities or social activities, which have largely been cut in most areas. The second is obviously, in, you know, with the current financial settlement, very hard to properly pay staff, and I'll come back to this in a minute, and provide training and investment in the workforce. And the workforce came through as one of the key determinants of quality. Provider stability, and I'll come back to this in a kind of question of financialisation a bit later, but very clearly, you know, we have to be slightly sceptical of some of the sector who say that the main problem is funding, because we know that there are some interesting business models going on that makes it very hard to understand the financial position of certain providers. But there doesn't seem much doubt that, you know, the funding settlement paid to providers has failed to keep up with costs, and is in places creating or contributing to provider instability, which in of itself has been shown to have some impact on quality, although the studies aren't great. And finally, local authority capacity is worth mentioning. Not a very sexy topic, but we spoke to a lot of commissioners who said, who to varying degrees said they felt able, capacity-wise, to properly manage the market of which they are legally responsible for, both financially in terms of the financial stability question, but also in terms of improving and driving quality. And in particular, the things that you know, the research and the experts suggest drives quality through commissioning. So things like support for workforce management, for reforming care models, for integrating with health and care services, you know, all of those things that you'd want your commissioner to be doing. You know, there's just a lot less capacity to do that without the funding settlement for local government. The second driver that we identified is, we call it the ownership model. I mean, I think, and I'll come back to this, it's not actually a binary thing about the ownership model. There are so in general, the data suggests that private providers, are more likely to be delivering substandard care than public and in particularly not-for-profit providers. That's what the CQC data set says. That would ring true with quite a significant literature from the US particularly, but also there are some studies in the UK which suggest that in general, not-for-profit providers deliver higher quality care than private providers. So that's the kind of basic story, but it's that I think that's too simplistic. In that, well, for a start, if you try and plot that at an area level, that relationship doesn't appear. So if you literally plot in an area at an aggregate level the degree of private ownership against quality outcomes in terms of quality from CQC ratings, that relationship doesn't exist. So it only exists at an individual organisation level. And then obviously we've got loads of private providers that deliver absolutely outstanding care. And I'm sure that there are many public and non-for-profit providers who deliver substandard care. So there is something else going on underneath that. We then have to go beyond statistics because the data will only tell us so much. And I think our emerging consensus was that the thing that's driving that is the care model itself and the business model. And what I mean by that is, if you have an organization whose ethos and whose culture and whose leadership, and this is backed up by CQC reports and their kind of findings, are focused on high quality relational care, a good work culture, what's best for the person in care, then what usually happens is that that's followed through with some of the better practices that deliver quality outcomes. So that might be about bringing in external activities that create that social element. It might be about much more personalized care planning. It might be about paying your staff properly and training them because that delivers high quality care. The thing that leads to worse care, as far as we can tell, linked to ownership model, is when the model is extractive, if you like, where the ownership model, and in particular I'm thinking here potentially of the epitome of this is quite a lot of the kind of private equity firms, although it's not exclusive to those, and some of them do deliver very high quality care. So but is where essentially the model drives you to cutting corners and to running it at scale like a business, in the kind of broader sense, rather than as a care provider. And so the studies that do exist suggest that, for example, those firms might look to cut corners by reducing staffing levels, reducing wages, with higher staffing turnover that leads to poorer quality care, or to kind of much bigger care homes delivered on a much less personal level, which are less kind of person focused, for example. So, the data tells you so much. It tells you that there's an overall trend. If you look at the literature and you do interviews, a more nuanced kind of message starts to come out about that definitely is linked to ownership model, but is not as clear cut as private bad, public good, which is not what we're saying at all. And it's worth noting in that context that we've seen an unbelievable shift in 30, 40 years from almost wholly kind of or largely state provided and voluntary sector to one which is almost entirely dominated by the private sector, and that shift is apparent even in the latest data. So this graph here shows the share of private company provision in 2015 along the bottom, 4 years later in 2019 across the side. Any dot on and each dot represents a local borough, and any dot above the diagonal line across is an area which has seen an increase in private company provision of care, and and any dot below is saying there's been a decrease, and what you see is 80% or more have seen an increase, and that's from an existing already a very, very high level. So we're getting into 80-90% of provision in lots of areas. The other thing about provider, which seems to come across, is the size of the provider. And again, that's a bit simplistic. Basically, what you find is that the larger the provider, the more likely the care is to be inadequate or substandard, and smaller care homes in general tend to deliver higher quality care. And I should have clarified at the start, we are talking mainly about residential care here, although the policy recommendations go beyond residential care. Again, I think this is the same story of there being some kind of overall trend, but the real story here is about the care model and the business model. And obviously the business model, particularly of private equity owned or larger care providers, has driven them towards larger units, which are more cost effective. And there's a story told traditionally by the left that drive has been because of the profit motive, and there's a story perhaps maybe by the right with a lowercase r. The more kind of small c conservative story would be that's actually been driven, or the story of the residential care providers themselves would be that's been driven by cuts to the unit cost. That means that they have to find ways of slimming down their costs, and that means having larger homes. Probably, I think both of those narratives have some element of truth in them. But what I think that's done is driven us, or is driving us towards a model where care is a bit like a kind of Fordist model of care, where you have big homes with a kind of managerial approach to care rather than a relational one, which is a bit of a generalization, but I think that's what we might be seeing in some of this data potentially, or that's what comes out of the interviews and the conversations we've had as a hypothesis for why this correlation might be there. And the final driver that we highlight in our work of quality is the workforce, and I actually think this is probably the most important one, although they're all important. What we see here is there is definitely a relationship between turnover and vacancies and quality. CQC have identified that as an issue, and this is definitely something that interacts with the ownership model question as well, because what we find is that pay is consistently less for private providers. Workforce staff pay is consistently less for private providers than it is for state or local authority, and that means that turnover is higher as well usually, and that is definitely a driver of some of the data that we've just seen above. The other thing that I would highlight that came out particularly strongly in our interviews was the importance of care managers. So obviously, when we talk about the care workforce, I think most people jump to frontline carers, and they obviously do a hugely important role. And COVID-19 has demonstrated just how important that role is. But the thing that commissioners told us was the one predictive factor, and several commissioners said almost the exact same words, the one predictive factor that they had at a local level as to whether care would be high quality or low quality would be the quality of the management of the care home in question, or the care provider in question. So one of the things that we're starting to think about is how do we up the training, the support, the focus on care home management and care provider management, given that's what the research is suggesting. We then also did a load of research, quantitative and otherwise, on the issue of stability, of the financial stability and the sustainability of the sector. And this has obviously become even more important in the current context, where the stability of the sector, there were questions pre-COVID. There are, those questions have only grown. I've written in big bold letters experimental here, because we did, and Future Care Capital led most of this bit of the work. We did some quite complex experimental work that in the end, we as IPPR and Future Care Capital decided not to put in IPPR's policy work, because we felt that it was, very, very interesting, but very, very experimental. And what we didn't want, we knew there was a high risk that the media would pick up on it and simplify it, and we didn't feel that it was yet robust enough to withstand or deserve that kind of media attention. But I think in this venue, it's a really interesting place to have this conversation, because we didn't focus it on it in our research, and I think there is appetite and there is thinking about kind of building on it a bit. So the work that Future Care Capital did with Cambridge Econometrics, that was originally, the plan was that this would feed directly into the IPPR policy papers, but in the end we decided not to put them in. Was a really ambitious attempt to first of all link 3 different data sets. The first kind of local government transactions, so local government data coming from Spend Network. The second was care home data from CQC. And the third was the financial accounts of companies that are available through Companies House. And what we tried to do was match up these various data sets to create new data sets which were integrated, that we could then do interesting analysis on about the link between finances, ownership model, and quality. Needless to say, this was a very difficult activity. I mean, again, I don't know all the details because I wasn't on the front line of doing this, but 2 conclusions that came out was, first of all, there's a, one of the overarching conclusions of all of our research was the data is so poor in social care that it's very hard to come up with firm conclusions on a lot of these things. So even the things that I've just talked through, which I feel are fairly clear-cut conclusions, if we were asked to rigorously prove in an academic paper, it would be quite difficult because the data is just not there. And that was very clear here as well, because this was our attempt to try and do something that was more rigorous, that would help us add to the kind of evidence base. The first problem is that local government data is very patchy, so there's a lot of it missing. There is not the responsibility to report in consistent ways at consistent times and completely report are just not there, and therefore there's a huge transparency issue here with quite a big swathe of government money that we should have much more transparency on. And the second issue is the same is true, if that's the local government transparency issue, there's an even bigger transparency issue, as many of you will know, on the companies side, and in particular, the larger companies, and those with more exotic financial models, shall we say, where, we really struggled to understand, well, first of all, get the accounts and then understand them and be able to put them into a system that would allow us to integrate into a data set. And so one of the caveats to this analysis is that some of the very organizations which we were hoping to understand more about their business model and how that impacted on care are the ones that we couldn't put in the data set, which is a kind of slightly cruel irony. But nonetheless, we came out of that process with a very, quite comprehensive data set, which in of itself, I think, is an interesting endeavor and innovation. What we then wanted to do was create a kind of index or a kind of way of using that data set to understand the risk or the financial vulnerability of the organizations and the providers, not at an individual level. We're not interested in any individual organization, but at a collective level, the kind of financial vulnerability of the sector. And the aim would be that ideally this would be able to be a kind of real-time tool. I think the idea long-term is that Future Care Capital wants to develop this in something that could be used as a predictive tool, albeit the fact there is an issue with the fact that obviously accounts data is often time-lagged, so there's a challenge there that needs thinking about. But we essentially, set up a criteria that we thought helped us to look at financial risk or vulnerability using a number of metrics that are listed on here, So, for example, does the provider have negative assets? Is its liabilities greater than the assets they have? Does it have negative equity, and what's happening to its profitability and its debt? And then, of course, what you'll see, the last two indicators are essentially a very kind of similar metric, but one that's showing kind of trend over time rather than the absolute level as well. So a set of metrics that we felt pointed towards, it doesn't prove anything, but it does point towards organizations that are, or providers that are more or less at risk from financial stress. And I should emphasize at this point that these are very experimental. We wouldn't want this, which is why we didn't ultimately publish it. We wouldn't want to kind of stake our brand, or indeed the brands of those organizations that will be being assessed here, because it is an experimental bit of work. But essentially from that work, what we estimated was, on a very cautious definition of risk, we estimated that maybe about 5% of providers, companies, are at financial risk. And if you take a much less cautious definition of risk, according to those metrics, you might find that up to 1/5 of them are. And my assumption, this was obviously all done pre-COVID, was that if we did this activity again now, or at least if we did this again next time there is new financial data available for these firms, we would find that metric of risk has gone up, because we have a systemic risk facing the sector, which is obviously playing out in the newspapers at the moment. And we were then, and it's worth flagging that we could do this when we did do it or FutureCare Capital and Cambridge Economics did it by region, to show that some areas systematically seem to have significantly more risk in terms of their provider sector than others. So it varies from 0.7% or 2% of care homes in London, up to kind of 7-8% in other areas, on the least the most cautious definition of risk. And does reach almost 30%, almost heading on to almost a third on the least cautious definition of risk. And again, all of this is very experimental, so I wouldn't want to overstate it, but there does seem to be some relationship between the financial risk of an organisation and the quality, according to care home, according to CQC. So what you find is that those who are outstanding tend to have lower risk than those firms so those providers who are requires improvement. Although there's a slight question, because actually that seems to decrease when they the correlation breaks down slightly when you look at inadequate providers, where actually the risk is less than at requires improvement. So there are definitely questions, as I say, to be asked about how reliable or not what we've found is, and that's what we're in the future going to look at, or FutureCare Capital are going to look at, is whether this can be turned into a more robust tool, and how confident are we with what it's showing us. So I will. So broadly from our research, what we took away was that on stability was that there is a clear challenge, which is that by whatever metric we see significant risk in the sector, vulnerability of providers, and from the kind of interviews and from the literature review, what we find is that is particularly acute for particular organizations that have very specific kind of business models, and in particular those that are very highly leveraged with very high debt as a result of financialisation in the sector. and that, we can't, and the lack of transparency in some of those business models means that we can't even do this very rudimentary analysis. We can't even include them in this kind of analysis to understand fully what that level of risk is. And that's one of the core problems that we identify, and others have identified previously, which is just that how on earth can the CQC and or the local government, local commissioners regulate financially if they are unable to understand the finances of those organisations and the risk level that they are bearing as an organisation. So I'll stop in a second. I wanted to wrap up by just saying, out of all of that research, what were our conclusions and what were our recommendations in terms of delivering a social care system that is, fit for purpose, that is, provides high quality care to all of those who need it, and where providers are stable and able to provide that care. So we basically split our recommendations into three categories, the three big drivers that we identified, so funding, workforce, and provider reform. On funding, we have argued, as I've said, that we need to introduce free personal care, but also commit to meeting the demographic pressures on the system, both those that we failed to meet over the last decade, but also those that we will face in the future. And we've argued that that should be funded out of general taxation. We're actually doing a piece of work at the moment with Policy Exchange to look at the kind of consensus across the political spectrum for how we move forward with something like this. And happy to talk about that in Q&A if useful. We did some polling recently, which is quite heartening, I think, on Conservative and Labour views of social care post-pandemic. And we also recommend the creation of a social care transformation fund to spread best practice models, because there is not enough focus on the kind of quality piece as well as on the just funding kind of better access and more care. On workforce, we have argued that the workforce needs to be at the heart of any strategy, any new funding deal, and any strategy to improve quality. We need to ensure that all care workers are providing the real living wage, and we think that there should be also a system of sectoral collective bargaining, as there is with the NHS, to drive improvements in other areas of workforce development. And there's a series of other recommendations about kind of training and also kind of workforce planning as well that we put forward over the last year. And then finally, on commissioning, we argue that, and on provider reform, we argue that there is a much more active role for the government as a commissioner of care, both at a national level and at a local level. And in particular, we argue for what we call an ethical commissioning charter, which would set down a series of requirements of any providers that are getting state funding to deliver care, including basic standards on workforce pay and conditions, on the quality of care that those providers are providing, and on their financial management and transparency, including on, are they paying their taxes? Are they opening up their accounts for external scrutiny? And that should be driven through. And obviously that has to go hand in hand with a funding settlement, but would be a way of ensuring that some of that funding, or most of that funding, is used in the ways in which we would ideally want it to be. We also made a recommendation on, we don't believe that we should nationalise care homes left, right and centre. We don't think that is a practical response. We also don't think there's enough evidence to demonstrate that it would deliver higher quality care in of itself. But we do think there is a more active role that the state could play in both shaping the market and also potentially in providing care. And one of the ideas that we put forward was a recognition that over the longer term we face a shortage of care providers, both residential care providers, but also alternative forms of care, so kind of housing and care, etc. and that the government could step in to provide some of that more cheaply than the private sector could. So in particular, they could fund the capital cost of building some of those care homes and or alternative care providers, because they can borrow at much lower rates than the private sector. And they could then either provide that care themselves, or they could outsource that care to ethical care providers, or social enterprises, the voluntary sector, and indeed potentially private providers as well. And I know that there are some local authorities, some areas that are looking at this. I know Hackney's looking at the idea of a joint care home that's run between the NHS and the local government so kind of pioneering some of this idea. And finally, we also kind of talk about the kind of financial regulation of the sector. And we recognise the role that CQC has played in recent years as a market oversight function, but that only regulates the biggest providers, and actually there's probably a much bigger financial regulation role needed in a sector that's this complex. Well, we've said to create a new regulator called Ofcare. Equally, you could expand CQC's role. It wouldn't necessarily have to be a separate regulator, but we need more regulation capacity within the system on finances is our main conclusion. And finally, Anne-Marie Naylor wouldn't forgive me if I didn't mention this, but just that the data is overwhelmingly poor, and unless we solve that problem, we will never be able to truly understand the drivers of quality and sustainability in the sector, and that a priority for government should be reviewing and changing the way in which data is reported so that we can do a better job than the one that we've attempted to do here, because the data was just so poor that it didn't allow us to do the comprehensive analysis that we'd really like to be able to do. So I shall pause there. I hope that was both interesting and useful. And